Hi, everyone. Welcome back to the 2025-2026 Oncology Pharmacy Resident Clinical Pearl Series. Today, I'll be presenting on my research project in which my co-investigators and I evaluate the appropriate use of initial empiric antimicrobial treatment and growth factor support for oncology patients with neutropenic fever. It's a pretty important topic because fibroneutropenia is a common, potentially life-threatening complication of myelosuppressive chemotherapy and a very costly one for health institutions across the United States. In 2012, total hospitalization costs for neutropenia among adult patients with cancer was $2.3 billion, while the cost per hospitalization was approximately $40,000. Both NCCN and IDSA recommend empirically treating this patient population with an anti-pseudomonal antibiotic. But when it comes to vancomycin usage, the IDSA guidelines does recommend this for very specific scenarios, such as if a patient has suspected pneumonia, catheter-related infection, skin or soft tissue infection, hemodynamic instability, positive blood culture suspicious for MRSA, previous infection, or colonization with MRSA. A focal point of my research project is what I like to call the 1-hour rule. And this comes from the ASCO guideline recommendation in which patients with fibroneutropenia and cancer should be treated with empiric antibiotics within 1 hour of triage and then monitored for 4 hours to determine if the patient can be managed in an outpatient setting or admitted to a hospital for further care. This is also backed by a prospective cohort study that was done in a tertiary hospital in Brazil that found that for any delay in empiric treatment by 1 hour, it would increase the 28-day mortality rate by 18%. The NCCN guidelines also does address when it's appropriate to use colony-stimulating factors for patients with cancer. And they first classified different treatment regimens based on the risk of fibroneutropenia, where high-risk treatment regimens have more than a 20% risk of causing fibroneutropenia, while intermediate-risk treatment regimens have a 10 to 20% risk of causing fibroneutropenia. They recommend the use of colony-stimulating factors in high-risk treatment regimens, and then for intermediate-risk regimens, it depends on patient risk factors. For pegfilgrastim, this can be administered 1 to 4 days after receiving a high-risk treatment regimen, and then the use of it could also be considered for low to intermediate treatment regimens to prevent fibroneutropenia. For the objectives of this research project, the primary objective was to evaluate whether patients with fibroneutropenia and cancer were appropriately treated with antimicrobials within 1 hour triage completion. For secondary objective, it was to assess if colony-stimulating factors were used appropriately in patients with fibroneutropenia and the incidence of neutropenic fever with new treatment regimen and cancer type. Patients in this research project were examined within a 1-year period from January 1st, 2024 to January 1st, 2025 in Monument Health affiliated hospitals. And this project specifically examined patients who presented to the emergency department for treatment of fibroneutropenia. Patients who were included for analysis were those who had cancer diagnosis on active treatment, temperature of at least 38 degrees Celsius over 1 hour period, and ANC of less than 500, because this was what the IDSA and NCCN guidelines defined for fibroneutropenia. For patients who were excluded from analysis, it was any patients less than the age of 18 and vulnerable populations. For the patients that were then analyzed for this research project, there were 10 patients total. Majority were female, had a median age of 67, and then with median temperature on presentation was 39.15 degrees Celsius. And the median white blood cell count on admission was 0.3. Half of the patients received pegfilgrastim the day following their treatment regimen. 40% had solid tumors and the rest had hematologic malignancies. What my project ended up finding was that none of the patients examined met the 1 hour time frame for antibiotic administration, but they did all receive appropriate anti-pseudomonal antibiotics. One caveat is that while the NCCN guidelines does recommend cefepime, piperacillin, tazobactam, and carbapenems over ceftazidime due to the fact that ceftazidime has weak gram-positive coverage, the susceptibility for Pseudomonas aeruginosa at Monument Health is 94%, so it was still appropriate to use this antibiotic. And 90% of the patients also did receive vancomycin, so gram-positive coverage would not be of concern. But vancomycin was used inappropriately in 2 out of 9 patients based on IDSA guideline recommendations. Filgrastim was also given to 3 out of 5 patients who received pegfilgrastim within their previous treatment regimen, where 2 of these patients did receive filgrastim less than 12 days from their pegfilgrastim administration. Ultimately, my plan with this project now is to present the results to medical oncologists at Monument Health and ED providers to see how we can improve workflow processes when it comes to the antibiotic administration time so that we can help lower the long-term mortality risk for this patient population. I also do plan on writing a formal recommendation to NCCN to add this to the guidelines, since this is not currently a rule that is on there, but I received good feedback at HOPA to write to them, since this would be a good revision to add so that health institutions across the United States can improve their practices for administering antibiotics in this more vulnerable patient population within a timely manner. If you do have additional questions regarding my research project, feel free to reach out to me at my Monument Health email, cchen1@monument.health. Thank you for listening to my presentation. I hope you learned something today. Thank you.